So I want to introduce Dr. Amy Holmes. She is one of our fantastic haematologists at Christchurch Hospital, and she also goes over to the Greymouth Hospital at the West Coast. She trained in Australia and is now settled in New Zealand, which is fabulous. Although Amy treats both malignant and non-malignant haematology patients, she also has a special interest in lymphoma. So just remember, if you have a question, just answer it in the pop it into the question and answer box, not the chat box, and there'll be plenty of time for questions during the talk. Okay, we will be finishing at 11:30 because we've got another talk straight after, so we'll be prompt with our finishing. So over to Dr. Amy Holmes. Thank you. Welcome.
Excellent. So are you seeing the slides there, Helen?
Not yet.
I'll share my screen again.
Fabulous.
Okay, how's that look?
Yes.
Wonderful.
Lovely. Okay, so we'll get started. Thank you, Helen, for that lovely introduction, and Matt as well for organising all of this. It's excellent to have an opportunity to talk to everyone and introduce you to some non-Hodgkin lymphoma information. I'm very aware that we've got a huge breadth of people out there with lots of different levels of understanding of non-Hodgkin lymphoma. So hopefully there's going to be a little bit of something in here for everyone. I've tried to extend the scope out, but there'll be plenty of time for questions. So please head us up if there's something that I haven't covered, and I'll do my best to field your queries. And now slides aren't progressing. Hang on. There we are. Okay, good. I have no disclosures. So today I thought we'd start off with a brief overview of some of the different subtypes of non-Hodgkin lymphoma that there are and what the relevance is of this, before focusing in on two of the main lymphomas that we see in New Zealand in our adult population, which are follicular lymphoma and diffuse large B-cell lymphoma. And of course, as mentioned, some questions. So non-Hodgkin lymphoma, what is it? So we're talking about a cancer of the lymphatic system, of the glands of the body. And really the lymphatic system connects cervical lymph nodes in your axilla, in your armpits, in your groin, as well as deeper lymph nodes throughout the body. And these are all connected with ducts and interrelationships with the blood vessels and the bone marrow, the liver and the spleen. So it's all one big organ. It's not something that you can easily just chop a chunk out and carry on. It's very different to the approach with solid organ malignancies when you're dealing with a hematologic cancer. There are lots of different types of immune cells in your body, as you're probably aware, and there's lots of different subtypes of lymphocytes. And because of that, we have lots of different subtypes of lymphoma. When we first approached lymphoma, we divided into two groups, the Hodgkin lymphoma, which I'm not going to focus on today, and non-Hodgkin lymphoma. And within non-Hodgkin lymphoma, we break that down into B lymphocytes and T-cell lymphomas as the two major entities, of which B-cell lymphoma is much more common. The subtypes of lymphoma also vary throughout time and throughout age. So when we look at this picture, we can see that the pediatric population, the young people who are over on your left side of the graph, have a lot higher prevalence of Burkitt lymphoma and Hodgkin lymphoma. Whereas as you get older, the proportion of patients which are suffering from diffuse large B-cell lymphoma, as well as the indolent lymphomas like marginal zone lymphoma and follicular lymphoma, proportionally increase quite significantly. So by the time we're looking at our adult population, which is the main group that I'm involved with treating, the majority of patients are diffuse large B-cell lymphomas and indolent lymphomas, with only a very small proportion of people having more aggressive lymphomas such as the Burkitt lymphoma, mantle cell lymphoma, T-cell lymphomas, or Hodgkin lymphoma. So I've mentioned these words indolent and aggressive a few times already. And really that's another way of subclassifying lymphoma, particularly relevant because it changes our treatment approaches. Indolent lymphomas like marginal zone lymphoma and follicular lymphoma are a group of lymphomas which will have a slow clinical course. They may have a long period of time between initial diagnosis and then subsequent problems and needing treatment. So there's a relapsing and remitting kind of approach that we use when we're treating these cases. That often then also goes along with them not being curable. Whereas aggressive lymphomas tend to present much more quickly with systemic symptoms, and these patients tend to go on to therapy much faster, and they have a potential for cure if they're of an appropriate age to be able to handle the treatment that's required. And so I'm going to focus now on one of each of these groups of lymphomas, the follicular lymphoma first and then diffuse large B-cell lymphoma, and we'll take some questions in between. So follicular lymphoma, as we've seen, is the most common of the indolent, slower growing non-Hodgkin lymphomas. It accounts for about 70% of non-Hodgkin lymphoma, and it is increased as people get older. So our median age of diagnosis is 65 years. We do see follicular lymphoma in people who are younger as well as older, but it's certainly not typically a pediatric lymphoma. The disease is considered incurable unless patients are treated with an allogeneic stem cell transplant. That's something that does happen occasionally for follicular lymphoma, particularly if people are very young when they're presenting and have recurrent lines of therapy. They may eventually end up with an allogeneic stem cell transplant, but it's not the standard thing that we would expect people to have with follicular lymphoma up front. The treatment is really directed by a combination of the disease and its risk of progression and the patient that you're treating. With all types of cancers, we always have to try and consider the specimen that we're putting the treatment into, need to make sure that we're choosing the right combination. And so there's lots of different treatment choices with follicular lymphoma. It's not a one size fits all. We'll talk some more about that as we go along. It is a variable disease with variable prognosis, and really the diagnosis hinges on a biopsy, and I'll show you why, because we classify lymphoma into different grades. The grading of the histology gives us some information about how fast the lymphoma is growing, how likely it is that it's going to need treatment soon, and it changes the biology a little bit. So crudely, looking down a microscope, we're already getting some information about the clinical biology of the follicular lymphoma. We grade people into grades 1 and 2, grade 3A, 3B, depending on how many of the larger cells that you can see on the biopsy. So hopefully looking at this, you can vaguely get the appreciation that in grade 3B, there's lots of cells that are a little bit bigger. They've got halar, larger nuclei, which is sort of the center, the part where all the DNA is and the cells are producing from there. And there's a lot more of those. Whereas when you look at the earlier grade, follicular lymphomas, there's a bit more of a mixture of cells. There's lots of different sizes. Some of them are really small, and those ones are growing but much, much slower. This grading is important because it changes our treatment a little bit. People who have grade 3B lymphoma with a much higher proportion of those larger cells are actually treated as if they've got a higher grade of lymphoma. They're treated a little bit more intensely because we know that there's a risk of progression and transformation in those patients is a bit higher. Overall, with all of the indolent lymphomas, including follicular lymphoma, there is a risk that they can change their stripes a little bit over time, and they can change into a more aggressive lymphoma, usually the diffuse large B-cell lymphoma. And that rate of change happens about 3% each year. And the diffuse large B-cell lymphoma is there in the right-hand corner. You can get the appreciation that there is only a small difference between 3B and diffuse large B-cell lymphoma, which is why it's treated in a different way. This is part of the reason why sometimes we rebiopsy patients, particularly if their nodes have changed or there's been a large period of time between samples. It's also the important reason why a larger biopsy is often helpful. And so depending on which lymph node it is that we're targeting, how easy it is to access surgically or with a needle, it's important that we get enough tissue. A piddly little core biopsy may not be enough to tell you what's going on the inside of that lymph node. And really the full architecture of the lymph node is really, really important for the anatomical pathologists. So apologies to anyone that's had to go back and get more and more biopsies done. This is the reason why we really need to know what we're dealing with. Along with the grade, we're getting more information over time about follicular lymphoma and some of the more intracellular and genetic things that are driving the lymphomas to grow or reoccur. But they're not really standard of care just yet in follicular lymphoma. That's more of a clinical trial thing that may eventually affect our treatments and our management. So that's grading. That's the histology component of assessing a patient who comes to our rooms with follicular lymphoma. The next thing is staging. So how far has it spread? We use in most of the non-Hodgkin lymphomas a staging system called the Ann Arbor staging system, which is lifted here from the Leukemia Blood Foundation booklet that you've all read and studied. And that helps us decide about treatment a little bit, particularly when we're dealing with indolent lymphomas. Stage 1 is localized really just to one lymph node, and stage 2 is above the diaphragm, both sites of disease being in the same side of the diaphragm. With stage 3 disease, we're starting to see lymphoma above and below the diaphragm, and with stage 4, it's starting to involve the liver and the spleen, the bone marrow, the blood, other organs. This is important because it changes your prognosis as well as your treatment. We can feed the stage and some other clinical features of patients' presentation into prognostic scores. And we often will do that when patients first arrive, and it gives us an idea about how likely it is that their disease is going to progress, what their overall survival is. The Flippy score is the most commonly used for follicular lymphoma. Increasingly, we're also getting information about how people then go once they've had treatment. If we treat the follicular lymphoma and it gets a really good disease response, but it comes back within 2 years, we know now that those patients have got a worse overall survival. It's around half of the overall survival at 5 years compared to people who've had a longer response to their treatment. And so that actually is quite informative, particularly if you've got a young person whose lymphoma has come back quite quickly. It does make us a little bit more concerned. So the treatment approach really depends on that stage of the disease, as well as how many symptoms that patients have come in with. Around 10 to 15% of people will present with limited stage disease in stage 1 or 2, same side of the diaphragm, potentially all localized within one radiotherapy field. And that's really important because a proportion of those patients can be cured with radiotherapy on their own. Some won't, some will have the lymphoma come back, but often that may be a reason why when people present quite early, we think about whether something like radiotherapy up front, even though they're asymptomatic, is worthwhile doing. The other patients will present with what we call advanced stage disease, where it's grade stage 3 or above. It's spread above and below the diaphragm. It's in multiple sites that can't be all encompassed within one field. And really then we need to think about whether patients are symptomatic or asymptomatic. Is the burden of disease very, very low and small, in which case they're not having any symptoms from their lymphoma? Those patients don't necessarily need to have treatment up front. They may go on for another 5 years without ever having exposure to chemotherapy and all of those side effects. And so really by treating those patients early, we don't necessarily improve their outcomes at all. And those people are told that they should be watched and waited or have active surveillance. Whereas the high burden, tumour burden patients who've got bulky disease, who've got abnormal blood counts, they may have systemic symptoms, those people are more likely to go on and need treatment upfront. I've already alluded to the fact that this is an indolent lymphoma. This is something that we treat when it becomes a problem. We get the disease under control, and it may have a period then of several years where no treatment is required before another treatment episode comes around. And so because of that, there's several lines of therapy that patients will be on, and some of them may have the same line of therapy, which worked really, really well, and we may do the same thing again down the track. Or otherwise, they may oscillate through different lines of therapy at different time points, shifting the ball a little bit on the lymphoma. The three main types of lymphoma treatment that are used for follicular lymphoma upfront are a combination of rituximab with cyclophosphamide, vincristine, and prednisone, called RCVP. CHOP, which we'll talk a bit about later because it's relevant to diffuse large B-cell lymphoma, and bendamustine, which is one of the most commonly used ones now for follicular lymphoma, as it's been compared to the others and has been shown to have equal efficacy, but better side effect profile. In the last few years, we've also had access through to maintenance rituximab. Maintenance rituximab is something that we've had internationally for quite some time, but it's now funded, which is great. And that would continue on every 2 months for 2 years. Rituximab is an antibody against the lymphoma cells. It depletes the B cells in the body, and in doing so also will lower your immune system quite significantly. So there's a long-term immune consequence to being on this therapy for 2 years. But we do know that it will prolong the period of time between initial treatment and when that treatment's needed again. And so we think that's probably a good idea, particularly in people who end up still having lymphoma, residual lymphoma at the end of their initial treatment of chemo, as those people are much more likely to then have an earlier recurrence. Autologous stem cell transplant is something that may come up in younger patients. That's something that isn't used first line, it's not upfront. But when they relapse, if they're still young, it may be that we treat them with a more intensive chemotherapy approach, collect their stem cells, and then give them back after a large dose of chemotherapy, which is a process called an autologous stem cell transplant. So that's several lines of therapy that patients can whittle their way through over many years with follicular lymphoma. And really the approach with a lot of the other indolent lymphomas is quite similar. We treat marginal zone lymphoma, for example, with quite similar approaches, although it may be slightly less intensity required with some of the subtypes of marginal zone lymphoma. There are new advances, as with everything. Overseas, medications such as lenalidomide are quite well recognised to have good efficacy in follicular lymphoma, although it's not funded in New Zealand for this indication. Obinutuzumab is a newer modified anti-CD20 antibody. It's like rituximab, but it's got a greater killing potential than rituximab, and it's particularly good in patients who've had lots of rituximab in the past and may have become a little bit rituximab refractory. And then there is a group of medications called the PI3 kinase inhibitors, which were originally developed for CLL, but do have some role in follicular lymphoma. And some of these treatments are in use overseas, but not necessarily easily accessed here at this time. And as with everything, there's lots of things in the pipeline, and a lot of the newer drugs that are being researched with follicular lymphoma, then looking at novel ways of therapy, stepping away from traditional chemotherapy, using small molecules to target the intracellular pathways and the signaling systems that are overly active and driving the lymphomas, as well as other novel ways of changing your immune system's ability to recognize and respond to the lymphoma. So these things are all available in clinical trials, and they're getting studied elsewhere in the world. And eventually we will see them starting to trickle into New Zealand. the best way to access them whilst you're in New Zealand is obviously through a clinical trial if there's one available in your centre. But that's obviously something that changes with time. So I'll pause there just in case there are burning questions on follicular lymphoma before we go on to a wee spiel about diffuse large B-cell lymphoma. Did you notice any questions popping up, Helen, that you wanted to point out to me? I haven't seen any.
Sure, no questions as yet. We may get some at the end of the talk. Yeah.
Yep, that's fine. Cool. So we'll chug along through then and talk about diffuse large B-cell lymphoma. So diffuse large B-cell lymphoma is the most common subtype of lymphoma that we see. It can happen de novo just on its own, or it could be in a small proportion of people that it's actually evolved out of an indolent lymphoma, like the follicular lymphoma that we've talked about, or marginal zone lymphoma. It's considered aggressive but curable, and it has quite a varied biology, and we'll talk a little bit more about how we're learning a bit more about diffuse large B-cell lymphoma as we go along. As with follicular lymphoma, when patients come with this subtype of lymphoma, we assess them and we put them into staging groups, and that really follows the same approach as we do with the follicular lymphoma. It's the same Ann Arbor staging system that we use. We use prognostic scores, the same as the FLIPI in follicular lymphoma, only this one's slightly different. It's the RIPI. And that gives us information as well about how likely patients are to respond to treatment and to go on to have a cure. But increasingly with diffuse large B-cell lymphoma, we're getting information from the pathology and from this histology to give us information about how resistant patients are. And this has really been building up over the past decade, that we've recognised different subgroups within diffuse large B-cell lymphoma which have quite different biology. The first way that people separate diffuse large B-cell lymphoma out is by the cell of origin. What's the cell type that has become abnormal and is driving the lymphoma? And that's separated out into the GCB group, which is there in green, and the non-GCB, or the blue group, which is the ABC subtype. Of these, the GCB, the green guys, have a much better prognosis and response to treatment than the ABC subtypes. Then more recently, we recognised that there were some proteins that were getting overexpressed, the MYC and the BCL2 proteins. And if those are overexpressed, we consider that to be a double expressor lymphoma. Those patients have an intermediate prognosis. It's not quite as bad as the GCBs, but it's not quite as bad, sorry, as the high-grade lymphomas. But they have a lower cure rate. And then the third way that we look at things is by looking at the genes that are regulating those two proteins, the MYC, BCL2, and the BCL6. And if those genes are mutated and rearranged, those patients we know have a much worse prognosis, and they may need to have a more intensive treatment approach if those patients are well enough to have it. That's a smaller group. It's only around 10% of patients with diffuse large B-cell lymphoma, but it's a really important subgroup to recognise, because when we talk to those patients, we need to be making sure that we're letting them know what our concerns are about their lymphoma. So all this information is great, gives us ideas about how people are going to go, but really doesn't change often the first line therapies that we're dealing with. And that's because the standard approach with diffuse large B-cell lymphoma is R-CHOP chemotherapy. Overall, if you take all of those subtypes together and lump them in a big basket, the overall cure rate is about 60%. But that's quite variable when you start separating people out into those different subgroups. A reasonable proportion of people, 30% of people, will present with an earlier stage disease where it may only involve 1 or 2 lymph nodes. And those people may actually be able to de-escalate their treatment a little and have a smaller number of cycles of chemotherapy, maybe with or without radiotherapy, to try and consolidate the response. And then the other time that we vary our standard R-CHOP backbone is those people that I mentioned, that 10% with double hit lymphoma, where those genes are rearranged. Those patients may go on to an infusional type of chemotherapy, where similar chemotherapy agents are used, but they're fractionated over several days and given at a higher dose. And by increasing the dose intensity, we hope that we can improve the cure rate for those really bad lymphoma cases. That's a regime called DAR-EPOC, but it may not be appropriate for all patients that come with double hit lymphoma. So R-CHOP, our old friend. CHOP chemotherapy has been around for donkeys. It's a chemotherapy regime that is effective in most subtypes of lymphoma. We use CHOP chemotherapy for T-cell lymphoma as well as diffuse large B-cell lymphoma. And really the reason why it's so common, we've done studies back in the early 90s comparing it to lots of different other intensive chemotherapy regimes, and it really didn't improve the outcomes. It just increased the toxicity by intensifying things back then. We then got rituximab in the early 2000s, and that improved things even further. So this is a standard of care chemotherapy for diffuse large B-cell lymphoma. But I've already alluded to the fact there's going to be a proportion of people that we aren't curing with this chemotherapy. And so what can we do beyond our CHOP to try and improve it? And over the past 20 years, we have tried, and lots of different studies have been done, looking at other things that can be added to the R-CHOP backbone to try and improve outcomes, particularly for those patients who have got those higher risk lymphomas like the non-GCB, the ABC subtypes, people who have got the overexpression of some of those proteins that we're worried about. But so far, most things haven't really paid out. They have tended to increase the side effect profile. And because of that, often treatments get delayed or doses need to be reduced. And so at the end of the day, you end up with something that's kind of equivalent to where you started. And so we haven't yet, in the New Zealand landscape, stepped beyond R-CHOP for diffuse large B-cell lymphoma for the majority of patients. The exception being those DAR-EPOC roles in double hit lymphoma. We know that double hit lymphoma doesn't do great with R-CHOP, and if we can improve things, then we do tend to try and step up the game on those ones. So we are trying. The reason I've alluded to already is that there's this unmet need of these patients that have got the worst lymphomas that we want to try and improve. The graph here at the bottom is our local data, and you can see that tracking along here at the top in blue are the patients who don't overexpress those proteins that we get concerned about, and they're doing very, very well. They're having overall survival and cure rates with R-CHOP chemotherapy of sort of 80 and 90%. Whereas people who are overexpressing the BCL2 and the MYC proteins are setting much lower in the curve. Still not terrible, but it's, it's sort of 50, 40%. And the people who've got those genes that are double mutated are then even lower. That's that green bar at the bottom, where you're looking at more like a 30% overall survival at 3 years. So those are the guys that we really want to try and improve over time, is trying to shift that curve up so that everyone's doing well up there with those blue patients. And clearly there's going to be patients that are relapsing with their lymphoma. And so what do we do then? Salvage chemotherapy is really the only curative thing that can be happening to try and get those people through. And that's usually with an intensive chemotherapy regime and an autologous stem cell transplant. But it's not great. There's a lot of people who are going to be relapsing who are over 70 who just aren't fit enough to have that level of chemotherapy intensity that they would need to get through to that cure. And in those patients, it may be that the more appropriate thing is low dose chemotherapy or maybe some radiotherapy to try and control symptoms of their disease, rather than pushing through to a cure. So sadly, there are people that are still dying from diffuse large B-cell lymphoma. We set out sometimes saying that they're going to try and cure this, but there's there is a group of people who just won't. And we can't talk about diffuse large B-cell lymphoma without talking about CAR T-cell therapy, at least very superficially, because it's the new kid on the block, and we've got Rob Winecove sitting in the corner. But this is something that's not accessible in New Zealand easily. There are clinical trials that are looking at CAR T-cell therapy in New Zealand. It is something that you will read about in the media a lot. And it is something that is standard of care in some centres overseas. But even in the places where it is publicly funded, it's not really appropriate for all patients. The reason being that you need a certain level of stability of your disease in order to have the CAR T-cell process even approached. And the intensity of the treatment and the side effects of the treatment are quite considerable. So what happens with CAR T-cells is very broadly, a machine is used to collect from the peripheral bloodstream the T-cells, the immune cells, which are then introduced to a virus which will sensitize them and change their antigen expression on the outside of the cells so that they will be primed to try and target the lymphoma or the malignancy that we're trying to kill. Those T-cells need to be in an adequate number that they can then be expanded and have a good enough cell count before they are reinfused back into the person. And there's lots of cytokines that are released in that reinfusion process as they recognize the lymphoma cell, as well as neurotoxicity that needs to be monitored in a very specialized way. And so, although this therapy looks fantastic, it does a really good job in a population of people who've got relapse refractory, very, very bad lymphomas. It's certainly not a walk in the park, and it's certainly not something that's going to be easily accessible in New Zealand for some time outside of a clinical trial setting. But it's exciting, and it shows you the new novel ways that we're approaching lymphoma and other malignancies to try and improve our outcomes and responses. And so there's lots of things out there in the future that are getting developed, that are coming through. There's different approaches to using CAR T-cell therapy to try and improve how well that they're working and how durable the responses are. There's ways of using antibodies to try and bridge the gap between the T-cells, your normal immune system, and the lymphoma, to prevent you needing to go and collect the T-cells and change their biology. We can use antibodies to try and target chemotherapy directly to the lymphoma cells. There are lots of different things that are getting developed, and there's a much broader understanding of all of the different pathways that are involved in lymphoma that are abnormal and driving the cancers forward. And I'm not going to talk about this. This is just to show you how complex things are. And all those little black names that are scattered throughout here are showing you drugs that are in development that are targeting specific pathways in the cancers to try and change the way that they're responding. And it's likely that one drug's not going to be the trick. It's finding the right combination of pathways to inhibit and try and stop the cancers, and approaching things without a chemotherapy backbone, or perhaps adding these things to chemotherapy. And that's where clinical trials are really, really important. And they're the things that are driving and changing our approaches to treating these things. And so I'll pause there and see if there are any questions.
Hi, Amy. Yes, there are a couple of questions. There's one there from Gary, who has had follicular lymphoma, grade 1, stage 4, and has been on the watch and wait for 8 years.
That's fantastic.
Yeah. So the question is, should he be treated or just stay on the watch and wait?
Well, although you have stage 4 disease, so that it's involving the bone marrow and it's extended to that level, if it's not causing any symptoms and the lymph node bulk isn't very high, the gain that you get from early treatment actually is fairly negligible. The Could be, if you really wanted to have treatment, a role for something like monotherapy with rituximab, but you end up having all of the consequences of that with respect to your immune system being impaired, because that will lower your antibody levels. It'll decrease your ability to respond to vaccines. It'll make you more at risk of infections. And so it's a little bit of a balance. If it's truly asymptomatic and it's low bulk, although it's a higher stage of disease, it doesn't necessarily improve your overall survival by having treatment early. And so it's an individual decision, and it's something to discuss with your haematologist, but certainly it's not strongly recommended that you would go on to treatment early.
So Amy, if you do have treatment early, does that are there treatments then later that you can't have because you can only have so many courses of one type of drug?
Not necessarily. It depends a little bit on what the treatment is that you've had. So there are some treatments that we wouldn't then repeat. For example, if you had a higher grade lymphoma, like if you had a grade 3A or 3B, and we treat with R-CHOP at the start, which is the more intensive treatment, that includes a chemotherapy agent called doxorubicin, which is an anthracycline and can impact on the heart. And so we limit how much of that we would expose people to. If people have had a very good response to a chemotherapy agent, there's not really a strong reason that you couldn't return to the same agent again down the track, but we do tend to cycle through things over time.
Okay.
The other thing is that the response to the treatment, the first time we treat lymphoma, tends to be the deepest and the longest lasting. And subsequent treatments often are shorter in the duration of the response. And so getting in there early and exposing those lymphoma cells to chemotherapy when there's not many of them doesn't necessarily help.
Okay, thank you. There's another question here from John. Does angioimmunoblastic T-cell lymphoma eventually relapse even after a stem cell transplant?
We can't often cure angioimmunoblastic T-cell lymphoma. Most patients will relapse eventually. There may be a small proportion of people who are cured with the stem cell transplant and autologous stem cell transplant, but it wouldn't be the majority of patients. But some people will have quite sustained responses to the treatment. It's a very variable disease, angioimmunoblastic T-cell lymphoma, and it's not a very common disease either. But I would be very cautious to be saying that people are all cured with an autologous stem cell transplant, definitely with AITL.
Tricky. Also, someone else has asked, I have had transformed disease twice with R-CHOP and recently an auto. How likely is this to happen again?
So I presume you transformed from an indolent lymphoma. So the rate of cure with the autologous stem cell transplant with diffuse large B-cell lymphoma in the rituximab era is around 20 to 50%. The autologous stem cell transplant won't cure the indolent component of the lymphoma. The idea of the intensification is really to try and take care of the high grade lymphoma component. It depends a little bit also on the nature of the lymphoma. Some people who've got the transformed lymphoma from an indolent lymphoma actually have accumulated some of those high risk genetic changes that I was talking about. And in those people, it may be quite a bit lower than 20 to 50%. And so it depends a little bit on the histology. There is a reasonable chance that it may come back, unfortunately.
Okay. And you had a question, Matt?
Yeah, actually two, yeah. From Amy, from off the call, there was like from anonymous question or two. The one was actually, oh yeah, well, you were talking about the R-CHOP backbone, and that's been around for quite a while now. They were just asking, like, is it likely to maintain into the future? Like, do you think that'll be around for quite a while? That's yeah.
Oh, it certainly seems hard to beat so far. That was sort of what I was talking about with all those extra things that are getting added in. We do need to try and improve our outcomes with R-CHOP, particularly for the people who are at higher risk. If you've got a low risk lymphoma, actually you do pretty well with R-CHOP, and perhaps those people we don't need to worry about quite so much. And I think it will change over time for those people. We just haven't got enough information, I think, about which people specifically need to have what other drug added in to really improve it. And that's sort of getting towards precision medicine, where you need quite a lot of big studies in order to drive that. So it may eventually change, but I think we're stuck with R-CHOP for quite a lot longer before things are going to really shift from there. With the exception of things like the diffuse, the double hit people who've got the double gene rearrangements. Those people we know don't do great on R-CHOP and often are escalated to something more intense.
Okay.
Yeah, there was one other question, if that's all right. Hey, Amy, there was one other question, again, anonymous from a patient. They were talking to their friends and family, and of course their friends are very familiar with like solid tumors and stage 4 cancer in the other types of cancer, thinking that's not really that curable. But this person with lymphoma was trying to explain that, hey, I do have the staging, but is it a little bit different because it's anatomical, stage 3 and 4? And they were trying to tell their friends that, hey, actually, there is still curability, sort of thing.
Yeah. The staging system is very different with solid organ malignancies compared to lymphoma. So people often are asking, well, does that mean is it metastatic? It's not really the same way that we think about with lymphoma. Because your lymph nodes are all connected throughout your whole body, it's all interconnected with your bloodstream and your organs. It's not the kind of lymphoma where you can say, well, we're going to chop this chunk out and then you're cured. With the exception of people who've got very, very localized disease, in which case we don't chop it out, we nuke it out with some radiotherapy. Certainly in stage 4 solid organ malignancies, typically the rule is that you can't cure that in most cases. But that's not the case with particularly the aggressive lymphomas. We often see them present at stage 4, but they are still potentially curable because they're growing faster. They're quite sensitive to the chemotherapy. So yes, the staging doesn't necessarily equal curability, although it does drop your rate of cure if you've got a high stage of disease, but it doesn't drop it to 0.
Okay.
Yeah.
And there's another question up there. It's with residual follicular lymphoma, are there any other treatments after you've had an auto?
Yeah. So we sort of talked about there being quite a few lines of therapy, and even if you've relapsed after your autologous transplant, hopefully that doesn't happen for quite some time, then you just sort of cycle back onto some of the other ones. So it may be that you had bendamustine and then a transplant, then you could easily have CHOP or RCVP as your next line of therapy, or there could be a clinical trial or something else that happens later. So we just sort of cycle on through all of the different options.
Okay. Well, that's all the questions so far.
Oh.
Have you got any more slides or?
No, that's me done.
Yeah.
So we're a little bit early, unless there's other people that are madly typing.
Okay, I think so. Hang on. Is it?
Oh, there might be one more. Let's check. Yeah.
Just check.
Okay.
So any comment, please, on having a bone marrow transplant for T-cell lymphoma, mycosis fungoides? I'm aware of one success story and have already been through numerous radiotherapy sessions and chemo treatments.
Yeah, mycosis fungoides is a tricky one too. So mycosis fungoides has lots of different, has a very complex staging system. So we don't use the Ann Arbor staging system for mycosis fungoides. And it has a very variable disease biology. In some people, it will be localized just to the skin, and local therapies with either just dermatology or with radiotherapy is enough. Other people will progress through to having tumor stage disease or involvement of lymph nodes and eventually the bloodstream, in which case we tend to start calling it Sézary syndrome. And as people progress through those stages, eventually autologous stem cell transplant or occasionally allogeneic stem cell transplant is appropriate. But if it's still just confined to the skin and it doesn't have sort of wider spread disease, then it would have less of a role. Mycosis fungoides tends to be fairly chemotherapy resistant, it's not very sensitive to chemotherapies, and so often more novel approaches are almost better for them, using things like interferon, for example, rather than going straight to chemotherapy. So it does have a role, particularly in very, very young people, but it wouldn't be something that we would be starting with at all. And often things that are local directed therapy, if it's only a local skin problem, has a higher utility.
Thank you. So just another one, is it usually rituximab on its own used for first treatment with grade 1 follicular lymphoma, or do they use R-CHOP and rituximab, or CHOP and rituximab?
So rituximab monotherapy is a very appropriate and fine place to start with treating follicular lymphoma. It depends a little bit on the bulk of the disease that you're trying to treat, and the fitness of the person. You know, if you're trying to treat someone who's quite a bit older and they've got a little bit of grade 1 follicular lymphoma, it's getting bulky enough that we need to treat it, but you're concerned about the robustness of the person, you're not really looking to try and cure that person's lymphoma for the next decade because they're already quite a bit older. Giving them something that's actually matching them, like monotherapy with rituximab, will be fine. Similarly, sometimes people will use monotherapy with rituximab in younger people just to try and keep things at bay a little bit longer before they need to give them larger chemotherapies. If the disease is pretty bulky, then often people won't go with monotherapy with rituximab. That would be something that we would use usually if things are lower grade and lower bulk.
And just another one. So if you fail your auto, is there a case then to go on to an allo?
Are we talking about autologous follicular indolent lymphomas or higher grade, I suppose?
Yeah, it's to say, but yeah.
If it's with a person who's got follicular lymphoma, and they've had and they're very young, and they've had an autologous stem cell transplant and they've relapsed very quickly afterwards, then yes, we do sometimes think about doing a transplant with an allogenic stem cell transplant, but an allogenic stem cell transplant, whilst we say it's a curative thing, has a huge amount of toxicity and health consequences. And there's still a reasonable risk of relapse of the follicular lymphoma despite that. So it's not a walk in the park, and it's not something to go into light-handedly, but there are a portion of people that it's appropriate for. And those are the people who are very young with follicular lymphoma that have had treatment, maybe with 1 or 2 lines of therapy, including an autologous stem cell transplant, and it's still coming back fairly soon after all these things, because we know that the duration of the response from each line of therapy gets shorter and shorter over time. And so if you're starting to whittle through your options and you've got a 40-year-old, then yes, it may be appropriate.
And just one about the oral treatments that are now available. So I think like the ibrutinib, is that? Yeah,
so ibrutinib, particularly for some of the other non-Hodgkin lymphomas like Waldenstrom's macroglobulinemia, looks really, really good. It's not funded in New Zealand. Ibrutinib for follicular lymphoma doesn't work quite as well as some of the other options, and it certainly doesn't have much of a role in diffuse large B-cell lymphoma as yet. But certainly in some of the other indolent lymphomas, it does look good, potentially combined with rituximab. There are other oral agents that are getting explored to add into these things, but a lot of them haven't made it through far enough that they'll be accessible in New Zealand soon. The oral therapy with lenalidomide combined with rituximab, I suppose, for follicular lymphoma is the other one, though, that does look quite promising and had fairly equivalent effect to conventional chemotherapy. And so internationally that is used for follicular lymphoma, but isn't funded here just yet.
Sure.
At a time, right?
Yeah. So we'll probably wrap up now, just to give an so thank you, Amy, for a very informative overview. Look, on the, especially the follicular lymphoma and the diffuse large B-cell subtypes. I mean, it's very sobering at times to hear the facts, but we do live in hope that the stats are on our side and that we know that there are amazing people out there working on new treatments for us. So just also to mention that this is Blood Cancer Awareness Month, and September the 15th is World Lymphoma Day. So there will be a lot about lymphoma going over our Facebook pages and things. So again, thank you very much, Amy, for giving up your time on a beautiful sunny Saturday morning here in Christchurch. Go out and enjoy it, wear your mask, have a coffee, and we're going to click out of this now. People take a break, and then the next talk is on this stream will be on with Dr. Rob Winecove. So thank you.
Lovely. Thanks for having me.
Thank you.